Evening, everybody. Thank you for joining another Totem Talk. I think our 40th or so Totem Talk tonight. Tonight we've got a talk from Segun Olusanya, who will be known to anybody who follows Totem. Segun's an ICU consultant at Bart's Hospital and a whiz with Echo, and he's going to talk to us for our first teaching on critical care ultrasound accreditation, which is long overdue because it was a big part of the purpose of why we started Totem in the first place. So thank you so much, Segun, for yet another talk. Over to you.
Thanks, Samson. I was just going to say, so I'll try and make this as interactive as possible. There'll probably be loads of questions to come up, so feel free to raise your hands. If Samson or somebody else could keep an eye on the chat, so if anybody has any burning questions, they can ask. Otherwise, save everything for the end. I've titled this talk "Everything You Wanted to Know About Accreditation and Critical Care Ultrasound, but Were Afraid to Ask." There'll probably be loads of things that I've missed out because I'm talking to a crew of the initiated as opposed to the uninitiated who I was talking to before. But yeah, my name's Segun. You know about me. My big declaration of interest is that, sadly, I have contributed in many ways to some of the alphabet soup of accreditations that are out there, in that I have contributed some stuff to FUSIC HD, to Genius, and a few other bits and bobs. But we'll talk about that as we go on. So it all gets very confusing when you are either approaching critical care ultrasound, you want to do a credential, or you're establishing critical care ultrasound, you want to do an advanced credential. You come up against all of these acronyms, and it can be really, really difficult to work out exactly what each is, what it does, what the differences are, etc., etc., etc. So I thought I'd start right from the beginning. So what is accreditation? So first of all, I actually think we use accreditation incorrectly. The true definition of accreditation is the recognition of quality of an institution, program, or organization. So it's a big body description. So your organization becomes accredited to do X. Whereas when it comes to individuals, the proper word that we should use to recognize the quality of, recognize the skill or the quality of an individual is credentialing. It's just that it happens to be used interchangeably in literature. So, for instance, the BSE will refer to all of their, will refer to their systems of training as accreditations rather than credentials. Whereas if you go to the States, the National Board of Echocardiography in the States will refer to their NBE as credentialing. There is also something else that is described as, privileging, which is essentially like a local agreement with an individual, local recommendation of skill, or a recognition of skill. So you might be privileged, for instance, to do something like, that classically happens with central line insertion. Most of us are locally privileged to do central lines without actually having any form of formal credential or accreditation to do so. So you'll see, if you read kind of in-depth pieces of paper on like accreditation / credentialing or whatever in the critical care ultrasound, you'll find all of the three different terms. But the way to think about it is, whatever you're going to call it, accreditation, credentialing, whatever it is, the way I think about it, because I do lots of martial arts, I think about it like wearing, like a belt or a badge of honor. And so what your credential says is you wear, a black belt is basically a way of saying, I have trained in this martial art to a specific level, and I have got a certain, and I have achieved a certain level of skill, right? And that's all well and good, but is that really what we're interested in? So this is a scene from one of my favorite movies called Kung Fu Jungle. And these two guys here are, they're both wearing normal clothes, but I think just by watching this short clip, there is in no doubt that these guys are incredibly skilled at what they do. So you don't need to look underneath their jeans to look for the black belt to know that they're good at martial arts. These guys are both awesome. In particular, this guy here, that's Donnie Yen. Donnie Yen is one of the best martial artists, one of the best movie martial artists in the world. So there's no doubt looking at this that he's good at what he does, right? So really, the whole point of all of this stuff that we're talking about is not the belt. It's not the credential. It's competence. And that is what we're trying to aim for. And so the thing to always remember is that your credential or your accreditation or your piece of paper, whatever that is, what that is a shortcut way of showing to your organization or to people around you that you have achieved competence, or a technique or a method through which you go through a training program that makes you competent. However, being credentialed does not mean that you are competent. You can be competent without credentials, and you can be credentialed without competence. And that's a really, really important thing to remember. So why is this increasingly important? If you work in the UK like I do, and in many other countries actually, but I'll use the UK as an example, the UK has just about semi-mandated echocardiography, at least focused echocardiography in the intensive care curriculum. So this is a letter that was written in JICS by Waqas Akhtar, and Waqas basically used to be head of the. You should actually tap him up for a totem talk at some point, actually. But Waqas used to be head of the training, not the trainee advisor group, of the training group of the FICM. And after many, many years of pressurizing the FICM have now agreed to have point of care ultrasound as part of the curriculum. And so there is going to be one of the new HILOs will involve the performance and interpretation of point of care ultrasound. And that will probably look like either doing some reflective practice or adopting it, not necessarily formal credentialing, but some kind of way of recognizing that this individual has skills and some degree of competence in point of care ultrasound. And all this is following in the heels of Europe. So some of you may have heard of something called COBITRES, competency-based training in intensive care. And this is basically the syllabus that was written Europe-wide for intensive care training. And COBITRES is what the FICM, well, soon to be College of Intensive Care Medicine, draw their syllabus from, and what the ESICM based their syllabus on. And COBITRES, probably now about 8 years ago, about 7, 8 years ago, mandated point of care ultrasound as part of training in intensive care. So for this group of people in TOTEM, this is really important because TOTEM is essentially a group of enthusiasts, people who are interested in critical care echo in particular, but also a little bit of general ultrasound. And you guys are essentially the next generation. You are going to be the people who are going to be coming through and certainly supervising, performing these scans and training the next generation of intensivists to perform and be competent at point of care echocardiography and point of care ultrasound. So therefore, you need to understand how competence, credentialing, accreditation works so that you can teach people how to do it. So what are the existing standards? So you have to understand that what over many, many years, because this all basically came out, in the 80s, Francois Jardin published his, seminal paper on using echo and critical well, and then gradually all the French people started doing it, and the French people insisted that we should all be doing it, and then they started all these roundtables, and people decided all these different things, and they started to break down what they thought point of care ultrasound should look like in the critically unwell. And there are two big groups. There is general ultrasound and there's echocardiography. And general ultrasound exists as a single curriculum, and then echocardiography exists as both basic and advanced. What there has been is so in terms of existing standards, there's this paper that was written, about 4 or 5 years ago now by the ESICM, led by Chiara Robba and by Adrian Wong. So the expectation from now on is that all intensivists should be able to do and should be trained in focused echocardiography, lung ultrasound, abdominal ultrasound, vascular access, and transcranial/neuro ultrasound. For echocardiography overall, it's a little bit more complicated, and that is because echocardiography is seen as kind of the backbone, a very, very important central skeleton of critical care and critical care assessment and hemodynamics. So this all started by the Echo ICU from WinFocus in 2008, and they built on some work that was done by the French guys, Antoine Villard-Baron et al. A few years earlier, and they came up with this structure, which many of you guys might have seen, what we call the pyramid of echo training. So they thought that all echo and critical care should go through these 3 phases. So you have emergency echo, which is really, really super focused stuff designed for ALS. Then you go to level 1, where you're able to do most standard views. Level 2, where you're basically a more comprehensive trained person. And then level 3 is a specialist in critical care echocardiography who spends most of the time doing critical care echo, and does weird stuff like 4D and contrast. And this echo pyramid has stuck around for a long time, and that's where our phrases level 1, level 2, etc. come from. That paper led to another paper, which was this was another consensus group in 2014, the expert roundtable, what's called the Paris document, where they came up with these ideas of training in advanced critical care echocardiography. And basically all these very clever guys in Paris all sat down, all the big names that you'll know in critical care echocardiography, and they decided what the cutoff was for advanced critical care echo. And they decided that what you see exactly on that slide, you need 100 transthoracic echoes and 35 transesophageal echoes performed over a period of about 2 years. And that, if you do that, that will achieve your cutoff in your learning curve for you to be considered a level 2 advanced critical care echo practitioner. You'll recognize those numbers because those numbers are now the basis of what we call the European Diploma of Echocardiography, or EDEC. Just to take things one step further, so this is probably the best way to think about it now. So this is a paper from 2019 written by the Australian group, the Australian Critical Care Ultrasound Special Interest Group, and they have broken critical care echo into 4 groups: into basic level, advanced transthoracic echo, advanced transthoracic and TOE, and expert. And it's very similar to Susanna Price's level 1, level 2, level 3. The difference is they split TTE and TOE into 2 groups because they recognize that the vast majority of people and vast majority of intensivists do not have access to TOE. So they created 2 separate groups. And the expert group is very similar to Susanna Price's expert group. These are people who've been, who are doing research, who are like at the cutting edge, super advanced critical care echo guys who've been around. So, people like Sam Ord, and people like that will be considered experts in critical care echocardiography. So do we actually need a critical care, do we actually need certification? This is quite an interesting little paper. And the reason why it's quite interesting is because it implies that from a medical legal perspective, certification is almost certainly required, because medical legally, if you perform an investigation, you need to be able to demonstrate competency to do that. And so therefore having certification programs are one way of making sure that happens. Many of you will remember that Ross Prager came and gave us a really nice talk in TOTEM, and he also authored this article on medical legal risks of point of care ultrasound. This was really quite interesting. They showed, so he looked at loads of cases and he found that 15 cases were related to POCUS. And what you find in the literature, and this is something that's repeatedly found in the medical literature, the vast majority of medical legal cases related to point of care ultrasound are due to not performing it. So therefore, it is quite important. So it's increasingly important then that if we're going to be doing point of care ultrasound, we need to do it in a way that makes sure that we're safe and we're doing it right. Okay, so now I'm going to talk a little bit about echocardiography and go into some of the different credentials. And there's lots of different boards out there, and so this is why there's so many different alphabets. There's so much alphabet soup, because there are lots of different people with slightly different ideas, all approaching echocardiography credentialing from a slightly different background. And there's different countries, and different countries have slightly different ways of doing it, and that contributes to the alphabet soup. So I'll start with focused echocardiography. So remember, focused echocardiography is meant to answer very, very simple yes/no questions. So LV or RV dysfunction, a pericardial effusion, gross evidence of low preload, and in most places now, a torrential left-sided valvular abnormality is considered part of focused echocardiography. So in order, the credentials that exist for basic echocardiography are Fusic Heart, or focused ultrasound and intensive care heart, the British Society of Echocardiography level 1. We have something called focused echocardiographic evaluation and life support, or FEEL, and then focused cardiac ultrasound. This is actually coming through the European Society of Cardiology, but they haven't fully launched this yet, and they haven't quite decided on their requirements, but I suspect they'll be very, very similar. There is one more, but this comes under a comprehensive credentialing system through the European Society of Intensive Care Medicine, which I'll talk about later. So Fusic Heart and FEEL are basically the same thing. They involve online registration. You need to get some kind of pre-learning, which will either be an online learning material or go to an in-person course. They are both 2D focused with no color and no Doppler. You need to do 50 scans, and you need to do triggered assessment. And they will train you to do, so I mean, the background to these training systems is that they're basically they were designed for shock states and cardiac arrest. So they're designed to capture very, very simple, gross things without going into too much complicated detail. So, and then if you move on to BSc level 1, it's remarkably similar, except that it allows you to put color over valves, and in particular over the left-sided valves. So they're both basically assessed. They all look at the same things, they're all designed for the same group of patients. But BSc level 1 and what I think focus from the ESC will have as well is the ability to put a little bit of color over the left-sided valves and see whether you've got torrential aortic stenosis or aortic regurgitation or mitral stenosis or mitral regurgitation. BSc level 1 is a little bit more formal in that you have to submit a formal logbook, and you have to do a formal exam, which usually involves scanning either so you have to go to an exam center and do a formal exam, which will either involve scanning a mannequin or a live person and getting some kind of marking of your live scanning. So that's what focused echo mostly looks like. Advanced echo is where things start getting lots more complicated. I know there are lots of people on the call now who are really interested in looking at advanced accreditation, and I get loads of emails and texts, probably about one every other week, with somebody going, "Oh, I want to do advanced echo. What credential should I choose?" So I will talk you through some of these because there are quite a few of them, and it will depend really on where you work and what you want to do. And unfortunately, advanced echocardiography often splits transthoracic and transesophageal into two different groups. So if you want to do full-on advanced echocardiography and you want to be good, especially in critical care, where we often end up having to use transesophageal route, you might have to do two different credentialing systems and two different sets of exams. There are some exceptions to this, but I'll go through them. We'll go through them one by one. So the vast majority of advanced accreditations will involve doing a written exam, submitting some kind of logbook, and they will often involve submitting some kind of video case assessment. So you'll have to record, basically take your best work, put it into a PowerPoint presentation, and then send that off to the accrediting body as well. One of them, the BSE, has a practical exam. The DDU, the Australian exam, has a Viva component, which is quite comprehensive and quite challenging, but I'll talk about that in a little bit later. And most of them have some kind of fixed time frame over which you do your exam and collect your logbook. And it's anywhere between 1 and 3 years, depending on your credentialing system. So we'll start with the BSE accreditations. So the BSE offers a number of different accreditations. So they offer transthoracic echo. They offer a form of transthoracic echo specific to critical care, which is called advanced critical care echo. They offer transesophageal echo. They offer stress echo, and they offer congenital echo. I'm not really going to talk about stress and congenital because they're not really applicable to critical care. So I'm going to focus on the first three. So the first thing to say about the BSE accreditations is there's good news for anybody who's doing it or anybody who's planning to do it. All logbooks collections have now been extended to 3 years. So the BSE used to be a 2-year, you had to collect a whole bunch of cases over 2 years, and it was quite a lot of work. But they've recognized that lots of people end up asking for extensions, so they basically just made it all 3 years. So that makes the BSE now a lot more realistic and a lot more achievable for people who are interested in doing this. So we'll go through it bit by bit. So for the BSE has a written exam component, a logbook component, and a practical exam component. They all have that. So the BSE written exam has 2 sections, a theory section and a reporting section. The theory section has 125 MCQs to be answered over 60 minutes. And the reporting section has 10 case studies with 5 questions each to be answered over 90 minutes. And basically all the BSE written exams will look like this. So whether you do transthoracic, transesophageal, or advanced critical care echo, they all have the same format. So looking at just the pure transthoracic exam, you have a written exam, you have 250 studies to do, which is cut down to 150 if you have a TOE accreditation, a recognized TOE accreditation from the BSE or the EACVI. You have to submit 5 video cases, and I'll tell you about the video cases in a little bit. You have to do it, and then after you've done that, you also have to come in person to see the BSE and do a practical exam and have your logbook assessed in person. The main thing here was if you do the traditional BSE level 2 transthoracic echo exam, this is designed for cardiac physiologists. So it's mainly about outpatients, and I'll show you what the case mix looks like. There it is. The case mix is basically a mix of lots of different stuff. And so there's lots of different things and lots of valves in particular. So you need to do lots of valves. 50 cases of valves, you need to do some LV assessments, you need to do some endocarditis, you need to assess some pericardial effusions, you need to do 5 simple congenital heart diseases, and then you are allowed to have up to 10 cases that are essentially kind of bubble echo and contrast studies, and you're only allowed 30 normal cases. Everything should be kind of mixed different diseases. And this is designed for people who are working, essentially, this is for physiologists who are working in outpatients, and this will cover the case mix of most of the stuff that they'll see in outpatients with a little bit of inpatient stuff. The video cases, again, are all focused around stuff that you, as a jobbing physiologist, you should see. So a normal case, aortic stenosis, severe valvular regurgitation, a regional motion abnormality, and then a miscellaneous case, which can be something weird and wonderful and something special. For your logbook, you need 250 full reports. So you need a full comprehensive report with all the measurements to be submitted via an online logbook portal. So you have to download all of your reports off whatever reporting system that you use and put them all in PDFs and upload them. And this is the bit where this is the bit that gets everybody about the BSE. So because you need a full report with everything, and your reports are basically the people who mark your reports will take random samples out of your logbook and mark them at random. So therefore, if you can have perfect reports and like 10 crappy reports, and if they pick up the 10 crappy ones, you fail your logbook. And this is why a lot of people struggle with all the BSc exams. For your video cases, they need to be a complete data set. So you're going to need about 60 pictures or whatever you take for a comprehensive transthoracic echo, and they need a full report, and they will be gone through in depth at your assessment. The BSc they're very comprehensive, and because they try to maintain a relatively high standard for doctors, they're really quite comprehensive as well to try and make sure that they maintain the same standards as the physiologist. Which brings us on to Advanced Critical Care Echo, or ACCE. It's pretty much the same thing as level 2, except that it's focused and driven towards intensivists. And 100 of those 250 studies need to be performed in ICU patients. And the logbook case mix is slightly different in that it's more focused on critical care stuff. So you need to be lots of assessments of shock. You're allowed up to 50 normals this time, but you're looking at things like refractory hypoxemia, volume state and preload responsiveness, abnormalities of the aorta, acute myocardial infarction. So it's very much you're a doctor looking after sick people and looking after shock states logbook. Your video cases, again, have a slight difference in that so you have one normal, one case has to be fluid responsiveness, one case has to be cardiogenic shock, and then the other two are basically a mix of whatever you think is best in your logbook. That's your transthoracic ones. The transesophageal echo one is a little bit different in that it's maybe the logbook numbers are different. So this time for transesophageal echo, a logbook of 125 studies is what's considered appropriate for the BSc, and you cut that gets cut down to 75 if you've got an appropriate transthoracic echo accreditation. Video cases are the same. The difference now is you do a practical exam. So for the BSc you do a practical for the BSc level 2 logbooks with ACCE, with TC and ACCE you do a practical exam where you scan a live volunteer, and you're asked for a very specific number of views, and you're marked on those views. For transesophageal echo you do a practical exam on a TOE simulator, and it's very similar, and you're marked on that. The BSc transesophageal echo, just bear in mind, it's designed really for cardiologists, and so it's mainly outpatient based. And so these are the kind of cases that you're expected to see. So, you ask to scan, mitral repair, mitral regurg, lots of endocarditis, a few bits of random bits like hypovolemia and shock assessments and pericardial effusions, but mostly it's all valve disease. And your video cases are a normal aortic stenosis, aortic regurg, endocarditis, and then you get a case 5, which is your miscellaneous case. So that's the BSc. The next popular accreditation for advanced accreditation for people to do in the UK is what's from the European Society of Cardiology, and it's called the EACVI accreditation, which stands for European Association of Cardiovascular Imaging. And they have 3 different forms of credentialing. So they've got transthoracic, transesophageal, and congenital. I'm not going to talk about the congenital one because that's a more specialist one. So I'm going to focus on the transthoracic and transesophageal, and there's quite a few people that do this. So again, the EACVI accreditation systems are really, again, focused at cardiac physiologists, but they have a significant overlap with cardiologists. And for the TOE exam, because they recognize that lots of anesthetists do it, the TOE exam has actually a significant perioperative focus. So again, similar to the BSc, they've got written exam, they've got a 90-minute, they've got 50 question reporting and 75 question theory. Or the other thing I didn't really mention is what the theory exams entail. The theory exams are basically things like, so there's always questions on ultrasound physics, and then there's lots of questions on, they might give you things like, they'll give you some parameters, like some physiological parameters, and like a mitral valve jet or mitral valve DPDT or whatever, and they'll ask you to do some hemodynamic calculations based on the mathematical equations that they've given you. They might ask you to calculate things like aortic valve areas and things like that. So you do need to do some work for these theory exams. The EACVI logbooks are a bit more strict. So they really intend for you to be doing lots of echo. So you've got to do 250 studies over a year, which is quite tight compared to the BSc 3 years or what used to be 2 years. The EACVI also wants you to do 6 video cases, and this is all marked remotely. The advantage of the EACVI, you don't have to do a practical exam. So your logbook needs to have 84 normal cases, and they've got these, they've got all these different pathologies that they want to see. Some aorta, some right heart disease, some pericardial disease, some masses, and lots of valve disease. The video cases are a normal aortic stenosis, a mitral regurg, an aortic regurg, a regional wall motion, and a miscellaneous case. The video cases are very different from the BSc. They only want 14 pictures, so they actually give you a table with the exact pictures that they want from this video case and the measurements that they want, and they don't ask you for a full report. For TOE, it's very similar. You've got written exam, and your logbook is 125 studies over 12 months with 6 video cases. And they've split the logbook depending on whether you're doing echo lab stuff or whether you're doing perioperative stuff. And so this is really, really good if you're an anesthetist or somebody who does perioperative echocardiography, because they basically designed this accreditation purely for you. So therefore, you can submit perioperative cases, unlike the BSc, which can be quite challenging to do if all you're doing is perioperative echo. For perioperative, you've got 6 cases: normal mitral, any mitral valve disease, any aortic valve disease, a major aortic case like a dissection or a hemiarch, and then 2 of the candidate's choice. If you're doing the echo lab, you've got left or right atrial pathology, a mitral valve, aortic valve, a major aortic, and 2 candidates' choice. And for each of these, it's just 14 pictures. So you can see that EACVI is in some ways more difficult than the BSc because you've got a shorter time frame. But the requirements, if you're in a lab that in a situation where you can get the numbers that you need, the rest of the requirements are much, much simpler. You don't have a practical exam. Your logbook submission is much easier because you basically submit a list. You submit an Excel file of your logs of your cases, rather than individual cases. So you don't have to submit 250 PDFs, and then you have your video cases are lots simpler. Which brings us on to the American one. So I'm going to talk about the American exam, partly because every now and again you find somebody who's done it. It used to be, and in the UK, it used to be the main exam that people did for TOE until like the mid-90s when the BSc and EACVI came along. So you still find people around who have done it. The National Board of Echocardiography exams are physician-focused. There's a separate bunch of American exams designed for sonographers. They're called RDMS and RDCS. But for echocardiography, it's the NBE that does it. And there are 4 exams that the NBE runs. For adult echocardiography that cardiologists do, called the ASC exam. They have 2 perioperative transesophageal echo exams called advanced PTE and basic PTE. Basic PTE is a bit that's basically just focused TOE for designed for people who are just doing, so it's like people who work in like simple centers or like more like community centers or intensivists who just want to be able to do a quick echo. And the advanced one is basically comprehensive perioperative transesophageal echo that lots of people do for doing things like structural heart disease or for cardiac anesthesia. Then more recently, over the last 7 years, they have a separate critical care echo exam, which is focused at critical care echo, and exactly what it says on the tin. The Americans have this weird thing called testamer versus diplomate. So testamer describe people who've just passed the written exam, and diplomate describe people who've passed the written exam and done logbook. The reason why they have it is because the written exam is no joke. It's 1,000 MCQs done over 5 hours. So, and it has lots of physics, lots of video content. It's a beast of an exam. And so passing that exam for many people in the States is considered you having an echo credential. So many people who have the testamer are like, oh, they've done they're essentially considered as being echo credentialed that way. And so there are many people who have the American exam, and that's what they have. They have testamer status. Diplomate status means you've passed the written exam and you've submitted a logbook summary, which is kind of a semi-Excel spreadsheet of required cases. So if you do the ASC exam, it's 450 transthoracic echoes over 3 years, and there's options to include transesophageal echo, stress echoes. If you do the basic perioperative TE exam, it's 150 focused TOE over 4 years. If you do an advanced perioperative one, it's 300 TOEs over 4 years, and the CCE exam is 150 TTs over 3 years with an optional TOE component of 50 scans. And then once you've done these exams, you basically maintain your certification by doing yearly you do a maintenance yearly through this weird app thing called MOTE. Well, that's one thing I forgot to mention about the EACVI and BSc. Your accreditation lasts 5 years, and after 5 years, you have to reaccredit with various amounts of scanning, with various requirements depending on how much scanning you do and where you work. Okay, so the last one we're going to talk about is the Diploma of Diagnostic Ultrasound, or DDU, and this is the big Australian exam that Sam Ord used to run, but has a significant part in running. So this is a significant undertaking. The DDU is essentially a big ultrasound diploma, and it has a written exam, a physics exam, short answer question, a viva, which involves live loop interpretation in front of a panel and some complex questions. And then you also then have to submit 5 video cases and do a logbook. And I'm going to talk to you about the logbook in a second. And you need to have at least 2 years of documented ultrasound experience. And the logbook for the DDU looks like this. It's 300 transthoracic echoes performed. 300 transthoracic echoes performed, 150 is reported, 50 TOEs, only 25 of which you have to do yourself. Plus, it also has an entire general ultrasound component. So you have to do 50 lung scans, 50 abdominal scans, 50 DVT scans, 50 line insertions, and 25 ultrasound guided procedures. So 725 scans in 2 years. It's no joke. So whenever you watch Sam Ord under the PN and watch all of those guys doing the DDU practice, this is what they're going through. It's pretty hardcore. So as a summary, if people who have done these advanced credentials have gone through, are considered to be working at the same standard of a physiologist or a cardiologist, the scans that you can expect people to do who've done these forms of credentialing should be pretty complete. Somebody who's trained to do these things should be able to do all kinds of echoes. So, and that includes more complex stuff like 3D, strain, contrast, etc., etc. I think trying to get these credentials, any of these systems outside of a dedicated ultrasound fellowship is going to be very, very difficult. They're really, really hard to do. You really need to spend, you need to be spending at least 2 days a week scanning, if not more. If you want to do something like the EACVR, that's 250 scans in a year, that's really, really hard. So you really have to knuckle down and give yourself over to just scanning people constantly for a year, 2 years in order to achieve this stuff. So now I'm going to talk about something that's slightly controversial, and I've used the label intermediate echocardiography, and I've labeled these systems intermediate echocardiography because these are all credentialing systems that a cardiologist may or may not recognize as the right to do an advanced scan. And this will vary again depending on where you work and what you do. And some of this is not necessarily because these credentialing systems are inferior. By no means, I don't think they're inferior. I think it's purely to do with recognition and the fact that people don't know what these systems are. And the ones that come underneath that are the European Diploma in Critical Care Echocardiography, or EDEC, FUSIC HD, or FUSIC Haemodynamics, FTOE, Focus TOE, and the NBE Critical Care Echocardiography exam. And these all have varying, so these are the requirements for each. So for the EDEC, you need 100 transthoracic echoes and 35 transesophageal echoes. You need 50 transthoracic echoes for the for FUSIC HD. Well, FUSIC HD also includes more than transthoracic echo because it's got lung ultrasound, and because of the VEXAS component, you've got the abdominal ultrasound, so it's quite a comprehensive scanning system. And FTOE, or Focus TOE, which is essentially basic TOE with color, but can do quite advanced hemodynamics, is 50 scans. So a little bit of an expansion on the EDEC, because the EDEC is is a big accreditation. It's growing all the time, and it's probably one of the more subscribed advanced echocardiography systems out there at the moment, and especially because it's specifically related to critical care. So the EDEC has several components. It's got a written exam of 50 MCQs and 10 video cases. It's got the logbook that you submit, which has got and the logbook has a mandated format. It's got a special submission form that you now do online. You allow 20% of those cases to be normal. It also has an educational component of 40 points, which require you doing various things. So you have to go to the main EDEC course, and you do a number of different courses and components that fills that out. And then there's a practical exam, which is done on a TOE simulator, and it's basically TOE focused because they want to know that you can actually put a toe probe down. You've got 24 months to complete the logbook in particular, but the timing of your logbook starts from your first case. FUSIC HD requires FUSIC out heart and lung as a prerequisite. It's all done in ICU patients. It includes echo, lung, and vector scans. It's a 50 case logbook with maximum 10 normals, and then you need a sign off, and then you've got a final assessment, which is done at the ICS headquarters with video pathology assessment, a logbook check, and a practical exam. So all of these assessments, the advanced critical care echo assessments, are unlike the general stuff where you basically required to scan everybody and learn about lots of valve disease and lots of general cardiology stuff. The critical care echo stuff focuses on stuff that makes people sick. And the way I summarize this is the hateful eight. So you've got LV dysfunction, left atrial assessment, RV dysfunction and venous congestion, pericardial effusion, preload dependency, dynamic LVOT obstruction, acute aortic syndromes, acute valvular dysfunction, and regional motion abnormalities and complications of MI. And this is what all of the critical care echo focused advanced credentials will be focused on. And so cardiologists may not necessarily recognize these because you haven't spent lots of time in clinic scanning little ladies with aortic stenosis. And that's what makes them controversial. They are ICU focused and they are great for ICU. And if anything, they're probably more relevant to ICU than your general accreditations, because they focus on ICU relevant pathology, and they also look at loading conditions and take that into account. So therefore recognize the impact of mechanical ventilation and anatropes on your echo. But because cardiologists haven't heard of them, you might go to them and say, oh, I've got this piece of paper, and they go, what's that? So therefore, you may not be able to scan everybody. So that, for instance, if you want to run a perioperative outpatient clinic, it may not be recognized by a local cardiology department. Just to add, if you're interested in looking at the way cardiologists see all of this stuff, Hassan, who's a friend to, one of our friends to TOTEM, wrote this, led this massive paper from the EACVI, looking at the requirements of cardiac ultrasound and emergency cardiac care, where they came up with all of these definitions, and they defined emergency echocardiography, focus, point of care ultrasound, goal-directed echocardiography, critical care echo, and focused transesophageal echo. So essentially, and ultimately, when you read all the stuff in the dictionary, it feels a little bit like siloing. What people are trying to say ultimately is they're trying to separate point of care ultrasound, which some people might just do at the bedside, having a quick look with a probe without saving their pictures, from emergency and limited echocardiography, which is going to be more comprehensive scanning done at the bedside by a physician, from a full-on comprehensive scan done by a cardiologist and physiologist. In the States in particular, this is very relevant because it's relevant for billing. So if you differentiate your echo done by a cardiologist from your echo done by your critical care physician as being different, then you can bill for them both. So there's always going to be an element of lines being drawn in the sand between these modalities, probably from that perspective. It's difficult, and I hate to say it, but it does feel a little bit like that. So if you constantly see people trying to draw lines in the sand between that, I think that's part of the driving factor. Some of it may well also be the fact that people get stung and people are worried about the relative credentials of people who have not been through a comprehensive cardiology training system, and people who have been. And that's why in my mind, that's why the ACVI have also written this. If you look at what they consider to be their levels of competence, it's very different from what I've just described. So for basic level critical care echocardiography, they consider you have to have done 350 transthoracic echoes. And for advanced critical care echocardiography, you need to have done 750 transthoracic echoes, 75 TOEs, and 100 stress echoes. So they are pushing for a very, very high standard for their understanding of critical care echocardiography. Now, I understand that this may be focused at cardiologists and at physiologists, but amongst those people are intensivists as well, so it's a little bit different. Just to finish off, I'm going to talk a little bit about general ultrasound, and there's lots of different ways of doing general ultrasound. In the UK, we have the Focus Ultrasound and Intensive Care Committee and FUSIC, and so they run all of the Focus Ultrasound in the UK, and so they have a modular system through which you can train in different modules. And there's a lung module, an abdominal module, a vascular access module, and a vascular module, a neuro-focus module that is just being launched, an airway module, and a blocks module that has just been launched. In the rest of Europe, there's something called General Intensive Care Ultrasound, or GENIUS, that's run through the European Society of Intensive Care Medicine. And this covers those basic ultrasound parameters that I told you about at the start. So basic echo, basic lung, basic abdomen, basic vascular, and neuro. And you can sign up to GENIUS as a single program, and it will train you all the way through from beginning to end in their training system. Other countries have their own specific system. So India has a fellowship in critical care ultrasound that's really quite comprehensive and goes through lots of stuff, including focused TOE. In Australia, you've got something called the Certificate in Clinician Performed Ultrasound, or CCPU, which has multiple modules. And in the UK, there's a separate modality. There's a separate training program for people who do acute medicine called Focused Acute Medical Ultrasound, or FAMUS, which is essentially FUSIC without the heart bit. So it covers lung, abdomen, and vascular. If you're a pediatrician in the UK, there's something called CACTUS, Children's Acute Care Ultrasound, which covers echo, lung, and abdomen. But they're going beyond this. There are actually even more credentialing systems. So there are many that are actually kind of online diplomas that you can kind of sign up to. And one of the first and the people who probably pioneered a lot of the stuff at this group, Win Focus. So you can still sign up to their courses and train online with them and train with them. They used to have online diplomas. They seem to have vanished now. But I'm sure if you have a look, then you might still be able to find one. And in certain countries where they haven't got established systems, this may be the best system that you have to train in focused ultrasound, period. There are also other online credentialing systems like the Ultrasound Leadership Academy, something called the POCUS Academy, and places like the GUCI, which is like General Ultrasound something Institute. And there's a new kind of worldwide Institute of Critical Care and Emergency Medicine that offers online credentialing in point of care ultrasound. So this is like a little summary of all the different accreditations. You know, somebody wants to take a picture. Well, this will all be available on the online talk, so you can have a look, and it just kind of compares them all and gives you an idea of what the different requirements are and whether or not they need a practical exam and all the different scans that you need to do. So if you're quite confused by this alphabet soup, please don't be afraid. You're not alone. It is very confusing, and I think there are too many credentials, and I think it's a problem. So what do I think is going to happen? What do I think comes next? Well, while I was musing on this, and just while I was writing this talk, last week, this paper was published, and this focuses on transesophageal echo, but it's a beautiful paper. I think it's an absolutely fantastic paper, and I recommend you all read it. This looked at accreditation status in perioperative transesophageal echo, and it was performed by the Association of Cardiothoracic Anaesthesists and Critical Care, ACTA-CC in the UK. And so they submitted the survey out to all the people that they've got on their books as being members. So that's most cardiothoracic anaesthetists in the UK members. They got a 33% response rate. So, and with that selection bias, half of the people who responded had a valid certification at the time of the survey, and 16% of them had their accreditation that had lapsed. And for me, the thing to read actually for this paper, what makes the paper golden, is that they had a free text box, which they got people to say what their thoughts on accreditation were. And this is what they described. People just found that it's really costly, it's really time consuming, it's very complex, and it requires a lot of effort. And they complained a lot about the logbook and case numbers. And this was their conclusion. Incentives appear lacking and barriers numerous in current systems. Change is needed. And I cannot agree more. I think right now there are so many credentials, so many different systems, with so much headache and little interconnectivity that it all just seems exhausting. And it makes you wonder, you know, if the goal of this is really competence and not the piece of paper, then why are we focusing so hard on the piece of paper? We need to make this and simplify all of this in some kind of way to make it that we can just go back to focusing on competence. So what do I think that looks like? First of all, I think there should be cross-recognition, and I think this is coming. The EACVI and BSE already cross-recognize each other. Fusic and Famous cross-recognize, but I think there needs to be bigger stuff. So, you know, so the EACVI needs to recognize the EDEC, I think, and the BSE probably needs to recognize the EDEC, and Fusic and Genius need to recognize each other. And that way, it means that across Europe, we all accept that all of these different credentialing systems are roughly the same, and therefore we can all do the same things. And so therefore we can all scan the same patients and come up with the same conclusions. Second thing to talk about is the fact that we still think of these things as single modalities. So this is a picture of me pointing out that you can do lung ultrasound with a transesophageal echo probe. So I'm pointing out some B lines behind the aorta with where somebody's looking at the aorta with TOE. So you have to recognize that we're not just training one thing, and that we need to come up with a comprehensive system where everybody can train. The DDU, I think, are closer to this than anybody else because they recognize that critical care echocardiography is not just echo. But we need to do this across modalities and just try to come up with actual training systems that are useful for us as intensivists and practicing clinicians. The next thing I think is going to change, that's going to be a big game changer for all this stuff, is AI. So this is AI basically telling you how to do scan. So you've got a beautiful AI algorithm that tells you you put the probe on the chest and it goes up a bit, down a bit, left a bit, right a bit. And so therefore the need to, we're at the point now where echo may soon become like doing a bladder scan, where all you need is just a probe and it doesn't matter who does it, the probe tells you what to do. And so therefore image acquisition no longer becomes about, you need to go to outpatients and scan 250 people. AI can also report. So this is something called Echo Prime, one of the scariest things I've ever seen. So basically Echo Prime is sitting down and just going through these images and actually going through and reporting the scan in real time. So therefore the need for everybody to somehow practice reporting over 250 scans may well also be diminished by the use of AI. this image is to point out something else that, you know, the whole credentialing thing kind of feels a bit weird, because look at these guys, right? You recognize them as doctors, they've got stethoscopes around them, but who looks at their certificate for using a stethoscope? No one looks at that. It's presumed that by qualifying as a doctor, you are skilled in using the stethoscope. And I think one of the things that I'd like to look forward to is a day in which point of care ultrasound in the critically unwell is seen the same way as wielding a stethoscope. So the fact that you are practicing in critical care means that you're expected to just have skills in point of care ultrasound. And that means POCUS, as we know it, will die. And POCUS, all the individual POCUS credentialing systems will die, and we will just focus on people who decide to get trained as advanced level providers and trainers for other people who are doing POCUS. And I think that I'm hoping that that's where it goes to in the end, and so therefore we can lose half the alphabet soup. I wrote a paper on this with Luke Flower, so if you want to read about training accreditation pathways and critical care cardiography, and I think that's the end of the talk. I'm going to stop my slides there and move over to any questions.